Most often we say mad people. No, they are mentally challenged. Many are mentally challenged, but few are on medication. Wait, let me teach you fully on how a client is clinically assessed whether he or she is mentally challenged. If today the first time you are chancing on this page, don't forget to like, share, and follow for more mental health updates. We have so many parameters that we consider to check before we can say, oh, this person is mentally challenged or mentally ill. So we have about 12 parameters, and in the clinical field, we call it mental status examination. So have time with me. Let me take you through these parameters so that you won't just conclude on one basic thing or one actual thing that a client will do to conclude that the person is mentally ill. So first, we have what we call identification of data. Mostly, this one is done at the OPD, or most hospitals is done at the records, where client's name will be taken, age, sex, marital status, occupation, religion, the dates of which the client has been to admission. Then also for also ask for informant or reliability. When I say informant, it's the one that brought the client for assessment or for admission. It could be a stranger, it could be a social worker, it could be relatives. They are the people that you rely on them to verify most of the things that the client will say. So these are the identifications that you are going to take from a client. So most often, as I said earlier, is done at the records or the OPD. So when you are going to assess a client, you have to know all these ones in order to rectify that. Is it the same client that you are going to do the assessment on? So after that, after clarifying that, the first domain that you check is the general appearance. How is the state of the client? You check the grooming level. If it is a lady and the client has done makeup, you check, is it the colors of the makeup, are they appropriate? Is it not multicolors? I'm not saying if a client or somebody has done a makeup and it's multicolors, the person is having mental problem. But you're looking at how the thing has been made. Is the colors matching the person's complexion? So you also check all those ones. Is it yellow, green, red, blue, maize colors? So you check that one if it is appropriate or not. Then you check the person's shoe hygiene. Has the person really bad? Is the person looking kempt, or is the client is unkempt? When you see somebody that is dirty, it will give you a clue that maybe something is wrong. So you also check whether the person is kempt or unkempt. Then you check the person's dressing. What exactly the client is wearing? Is it a trouser with black shirt? Is it a cap with earrings and stuff? So you check all those ones, how the person has put on the clothes. Then you check the situation. When I said the situation, for instance, some client maybe he'll be misbehaving in a funeral center, then they'll bring him. So you check the situation where the client was in the occasion. That the client was at a funeral. The costume of which the client was wearing, does it suit it? Or is it appropriate for the occasion? You're assuming a client or somebody wearing funeral clothes to your naming ceremony or maybe your wedding. It tells you that how the person has dressed is inappropriate. So it can give you a bit clue that, something is wrong with the person. Then you also check the person's posture. If the person is sitting, how is the person sitting? Is the person having any back hump? Is the person having any rigidity in the sitting position? Has the client assumed a position where adjustability is not that there, that the person assumed that position for a long time without making any flexibilities? You check all those ones. Then you also check if the client is making any eye contact. When you are talking to the client, does the client maintain eye contact or the client doesn't look at you at all? So you also have to check that one. Then check the client's to his or her facial expression. If the client is in pain, you see it in the face that the client has frowned or maybe something like that. If the client is happy, it will show in the expression for you to see. So you check the facial expression as well. Then you check physical abnormalities. Mostly this one thoroughly. You have to strip the client naked to check to see if everything on the body is intact. Like there are tattoos, there are scars, there are tremors. When I talk about scars, it could be maybe accident scar or maybe operation scar. All those ones give you clue about the client's condition. Sometimes maybe the client has had accident before and there is a cut in the head. It will tell you that maybe when the client fell, it affected the brain. So all these ones are very important. So when you are checking the client's physical appearance, you check the body formation as well to see if everything is intact. Sometimes you have people that they have 6 digit fingers. So you check to see is the client having all those ones. You check the size of the ear. Sometimes you use those ones to classify different conditions as well. So you check everything. Is the eye appropriate? Is it the same normal size as human being's eye? The nose, is it at the same position like human being? The mouth, how the size and this. You have to check all those ones to see. So everything is perfect, especially sometimes you have to check the size of the head. It all gives you clue that, oh, maybe client is having genetically deformities that is causing the mental condition or something like that. So it's not just done for um fans sake or something. They all gives clue about how the client is being affected and how you can know where the problem is emanating from. Then you also check the nutritional status of the client. All these ones is part of the appearance. If the client is not eating, the client will look lean, client will be malnourished. So you have to check all these ones. And the very important thing, most times clients will tell you they have not eaten. You don't just pretend as if you've not heard him or her. Sometimes it's very important. Back in the days, it's hard to come by glucometer. So if client tells you they have not eaten and you don't pay attention to it and you go and administer any medications at all, it can cause harm to the client to a point where you can even kill the client. So you have to pay attention to the nutritional status of the client. Client will tell you they have not eaten. Ask the client, when was the last time that you ate? Or even if you have eaten, what did you eat? So that you know that our client is really fed well or something. So if you are even administering medication like PRN and stuff to calm the client, you know the amount of fish you are giving. Because if the client is not eating and you give excess, it can cause harm to the client. But these days too, we have other ways that you can use, even glucometer, to check to see the sugar level that the client is having, to know the amount of dosages of medications or anything that you are going to do for the clients. So the next point is behavior and psychomotor activity. Whilst you are assessing the client, you check the client's cooperativeness. Is the client cooperating or the client is not cooperating? You also check for whether the client is agitated. When it comes to mental health, most of when you are bringing the client from the house to the facility, we force them. So mostly they are agitated. So it's hard sometimes that even to talk to them. So you ask you have to examine the client to see whether the client is agitated, is the client restless, or the client is calm. Sometimes some of the clients are calm, some too they are restless, don't even sit at one place. Even sometimes when you're talking to them, they'll be moving up and down. So you have to check all these ones. Then you check their psychomotor retardation. When they are walking, are they slow? Are they walking fast? Or it's normal? You have to check all those ones. Then you check for abnormal movement. When I say abnormal movement, you check for catatonia, you check for mannerisms, tremors. Most of the alcoholics, they have tremors. You have to check, because if you are able to detect that client is having tremors, you can tell you that, oh, this client has been using alcohol or something. It will give you a clue. So without even doing urine testing or something or other tests, you could even have a clue that a client has been using alcohol. Then you also check for tics. When I say tics, we have types of tics. We have motor tics. We have vocal tics. When I talk about the motor tics, we have excessive blinking of the eye. You are talking to client, the client is blinking the eye excessively. Facial grimacing, client has squeezed the face as if something is wrong with him or her. So you have to check all those ones. Then you check head jerking. You are talking to client, the client has been jerking the head from top and down, side to side. Then you know that all these ones can help you diagnose clients from different conditions. So all these ones are very important. You can use this one to diagnose clients suffering from ADHD and stuff. So all these ones have a purpose. You don't just do for doing sake. You are doing this one to record them. If it is not what the client is presenting, right, can give you clue that, oh, client has suffered this before, client is into this. So all these ones are important. Ticks, you can also check for nose twitching. Client will be there and client will be doing some signs with the, with the nose. All those ones are important. They also check for the vocal tics. The vocal tics, some are clearing of throat. You are talking to client and every 2 seconds, client is clearing the throat. You check for sniffing. You are talking to client will be there and doing sniffing from here to there. So you have to check those. And then sometimes they are coughing, they make coughing sound. Not that they have cough, but it's kind of mannerism that they do. They will be coughing, small cough whilst you are talking, and it's not that just once then they stop. They continue to do it whilst you are having a chat with them. And sometimes they repeat words. You say something, the client should repeat the same thing. So you have to check all those ones. Then the next point is you check the speech. When client is talking, this one, you are checking the characteristics of the speech. It's very important. When the client is talking, you are going to assess the characteristics of the speech. Is the rate okay? Is it low? The rate at which the client is talking, is it low? Is it normal? Or is rapid? You have to assess the client to know all these ones. Some people talk on top of their voice. So while the client is talking, you check the rate as well. You check the volume of the speech. Is it soft? Is it loud? It's very important. Then you check the tonation, the tone of which the client is speaking. Is it normal tone or is it abnormal tone? Then you also check the fluency, the spontaneity, then the coherency. What client is saying, does it make sense? You check all those ones. Then the other domain on the assessment label is the mood. When I say mood, the mood is the subjective emotional state of the client. They are the things that client will tell you. You are having a chat with client. Client will tell you, I'm very angry. Don't bother me. I'm very sad. I'm anxious. I'm very irritable. Sometimes they'll tell you I'm happy or I'm angry. So these are the things that client is going through. They are emotional instabilities that the client is going through. So client will voice out and tell you all these ones. It tells you that these are the mood. The other domain on the label is effect. I've explained to you the mood. The effect is once client is telling you that I'm very sad. What are you seeing? Or what are the facial expressions that you are seeing to confirm that, oh, indeed, client is very sad? They are the ones that we call effects. So they are the observable features or expressions or emotional expressions that client is exhibiting whilst the client is saying, I'm irritable. The actions, the facial expressions that client is putting on, that you, the individual that you are assessing, you are seeing, is the effect. So what you are going to check is that is client having blunt effects? Is client having restricted effect? Is client having flat effect, or is it full? If you say something to the client, right, and client will be laughing, whilst the thing is not something that is funny, it's inappropriate. So client responding to something that you said that is not funny in a way which is funny. So it tells you that something is wrong with the client. When you say something is funny and clients will respond to it funny way, or start laughing fully, then realize your client is responding to whatever that you are telling him. But sometimes too, the thing, whether it's funny, it's sad, or whatever, client will not show any expression. We call it flat effect. Whether the thing is sad or funny, you sometimes you tell clients that your mom is no more, your mom is dead, then clients will not show any expression indicating that he's sad. Or you tell client that, oh, your visa is ready, so probably next 2 months you are going to travel. Then client, instead of him to be happy, client to not show any expression showing that he's happy or whatever. Sometimes too, the thing that you tell them is happy, then they will be sad. It's inappropriate effect. So sometimes too, it's blunt, though they will show the expressions towards everything that you are going to say, but it wouldn't be in full that, oh, it warrants that they laugh and be more happy, but then you see them being just smiling, then they'll pause. So you have to observe all these ones. Then the other part, other domain on the label is thought process. When I say thought process, is the form of the client's thoughts, how the thought is being formed, how the client's thought is being organized. So we have whilst you're talking to the clients, we have something that we call circumstantiality. As when you ask clients something that, oh, why is it that I didn't bath today? Instead of client to go straight forward and say, oh, because there was no water, that's why I didn't bath. Client will not tell you that. Client will tell you a whole long story before coming back to the question or coming back to give you the response that, oh, there was no water, that's why I couldn't bath. That is circumstantiality. Then we have tangentiality. That one too is similar to circumstantiality. You ask clients that, why didn't you bath? Then client will give so many excuses trying to tell you why he didn't bath. But at the end of the day, he will not even tell you that because of this, that is why I didn't bath. Not that it's intentional, but sometimes they even forget that you have asked them that, why didn't you bath? But then they will say a whole lot of things without responding, why didn't you bath? Then we have flight of ideas. Flight of ideas, clients, you ask clients, why didn't you bath? Then as soon as the client will start that, I didn't bath because you not finish that statement. You bring in different idea. I didn't bath because you told me you buy me food. Why is the food? Then have you given my medication? No, I'll not sleep. My mom told me that. So it's like client will not finish one thing. He'll be jumping from one topic to another. When it happens like that, they're having so many ideas on mind, and because the thought is racing, they don't have time to finish one and move to other. So they keep on jumping from one to another without landing one particular statement that they are supposed to. Then we have thought block or thought blocking. That one too, um, you ask clients, why didn't you bath? Then clients will be then, oh, I didn't bath because then client cannot continue anymore. Mostly, they will not even remember what they began the statement with that I didn't start because they don't even remember. So they will just pause, then they'll ask you, what was I saying? So that is thought block, having a pause in between a statement when the client is coming to respond to something. Then you also have loose association. Loose association is a bit similar to ideas of flight of ideas, but this one, list of reference refers to the breakdown in the logical connection between thoughts. Like for instance, um, clients, you have asked him, why didn't you have, or maybe client is talking, then client will tell you that I went to school. He will not finish the statement, but because he said I went to school, then he will be like, school is cool. He will not finish, then you use the same cool, then he'll be like, cool weather makes me think of ice cream. You understand? Then ice cream melts like people. So client will he's shifting from one topic to another with little or no meaning between the links of what he or she is saying. Sometimes it's linked, sometimes it doesn't even correspond or to each other. So that is loose association. Then another domain on the label is thought content, what the patient is thinking. Whilst you're having the chat, what is the patient thinking about? That is the thinking pattern of the client. And this one, you are going to assess for what you call delusion. When we say delusions, they are fixed false beliefs that is firmly held despite evidence that what client is saying is not true. But clients still believe that no, what I'm saying is the truth. So under this one, we have so many types of delusions. So I'll talk about only three. One, we have persecutory delusion. Here, client will tell you that people are trying to kill him or her. People are conspiring to kill him. Those that sometimes you'll be like, the other clients on the ward there are planning to kill him. They have been sent from his or her family to kill him. Sometimes the client will be like, he's God. We call it grandiose delusion. Trying to tell you that he's God. He's the Son of God. He's Jesus Christ. Sometimes they'll tell you that you don't know me. Me, I'm the president of Ghana, or I'm president of Namibia. Sometimes they'll say, oh, I'm the president of USA. So these things, we call them grandiose delusions. Sometimes clients will be walking on the world with Bible, praying every dawn and reading Bible. We call it religiosity. The truth is that when they are not sick, in rare sense, they will not even go near Bible to the extent where they are going to pray or they are going to read. But when the condition sets, they become very religious. Everywhere they are with Bible, reading, praying. Most times, the prayer, it doesn't make sense because they say um, things that are not making sense. Let me put it that way. So you check about all forms of delusions to see if client is having delusions or not. Then we also have obsessions. Some clients, if you ask them to wash their hands, only their hands, they will wash it like for 10 minutes. They wash their hands for like 10 minutes. So you check for all those ones. If you ask him to count money, you count the money, knowing the exact amount that he's having in hand, but still he will be having this thought that no, he didn't count it well. If you go to their rooms, they have everything in order. If you even mistakenly push something from the arrangement, they have to do it again. Sometimes they'll lock their door, planning to go somewhere. On their way going, they'll be like, no, I didn't lock my door. But the truth is, if locked, they will come back to check if they have really locked the door before they will be satisfied. So we call them obsessions, things that they do them repeatedly with the idea that they didn't do it well. We also have phobias. So um, irrelevant fears, fears that are not appropriate. Clients will see maybe cockroach and clients will be shouting and crying, screaming, as if maybe a snake has come to his yard or something. So all these ones you have to check whether the client is having any phobias. Is it social phobia? Is it agoraphobia? We have so many types of phobias. So you assess clients on the few ones that will come in mind. Then you also check the suicidal tendencies of the clients. You check for the suicidal ideation. Can clients commit suicide? Sometimes you have to ask the client when he or she is having delusions, like somebody wants to kill him or somebody is talking to him, blah blah blah. You ask him or her that have you planned to kill yourself before? Do you intend to kill yourself? If clients want to commit suicide, client will tell you that yeah, I want to kill myself. When it happens like that, then you ask client, how do you want to kill yourself? What are the means that you use to kill yourself? Then client will be like, oh, I'll hang myself. All these ones will give you clue that the client that you are receiving, the client that you are going to work with, have suicidal ideations. So let me work this way in order to prevent it. And if you ask client to know how he wants to commit the suicide, it will help you to prevent it. And you also check for homicidal ideations that is client safe to be with other people. Sometimes clients will not help harm themselves when they're having persecuted delusion, they don't really harm themselves, but they feel that others want to harm them, so they will intend to retaliate. So they intend to harm people around them. Not that they have this plan that they just want to kill them, but on their mind they feel like those around them wants to harm them, so they will intend to retaliate. So you check to see, say, if client not having any suicidal ideations, you ask to find out. If you don't ask, you will not know. So you ask clients why is there anybody on your mind, or is there anybody in your mind that you plan to harm or something, trying to tell you when they are going through this condition? Not mostly they lie, but things like this, I don't know why, but they tell you the truth. Then another domain on the label is perception. These are the disturbances in the client's or the reality, the patient's perception. So here you check for hallucinations. You have so many hallucinations. We have auditory hallucination, visual, tactile, olfactory. There are all kinds of types of hallucinations. And when I say hallucination, it's a perception without an external stimulus. Client is saying something, whereas you, the individual you are with, you don't see or you don't hear something like that. So under the auditory, client will tell you that I'm hearing voices, and a voice is telling me to come and slap you. A voice is telling me to kill my mom. A voice is telling me that some people are plotting against me. But sometimes you have to ask the client, what are how do you hear the voice? Do you hear the voice through your ears or in your imagination? Because sometimes clients imagine When it's imagination, it's not hallucination, but if it is through the ears, client is hearing it through his ears or her ears, is auditory hallucination. Then we have visual hallucination. Clients will tell you that I'm seeing strange images. All these ones you have to ask the clients because most often they don't say it. Though you see them talking to themselves, but sometimes you wouldn't be able to pinpoint whether it is visual or auditory unless you find out, you ask them or you prove them further before they can tell you that, oh, I'm hearing, I'm seeing. If client tells you that I'm seeing, before you can confirm that it's visual hallucination, you have to ask the client exactly what he or she is seeing. If it is human beings or images that he's seeing, you ask him or her, is it, if it is human being, what is the complexion of the human being? What is the attire the person is wearing? The color of the attire the person is wearing? In order to see them, because sometimes clients will be telling they are seeing images, but it's not so. So if you don't take care, you end up administering different medication to them. So you ask the client exactly what he or she is seeing. You ask the client, is it the person male or female? What you are seeing? If it is structures, you ask the client to um, describe exactly what the structure is and even the color of it. Then you have tactile hallucination. Client will tell you that beginning things are running on my head. Some things are crawling on my skin. Sometimes they'll tell you that insects are on his skin crawling there, so you give him medication for that. Sometimes they'll tell you that somebody has touched me. Despite the fact that nobody has touched them, they'll be complaining that, and you have been touching me. Why are you doing this to me? Stop touching me. Am I your boyfriend? Am I your girlfriend? They'll be giving you excuses that somebody is touching them, whereas nobody is touching them. They are all hallucinations. You also have olfactory hallucination. Then olfactory is a sense of smell. Client will tell you that, oh, I'm smelling. Often they have unusual smell. You know, they will tell you that the food is smelling like carcass, and I'm perceiving or I'm smelling what do you call it? Perfume. Who has used this perfume that is strong like that? Meanwhile, nobody has used perfume. They'll tell you that, oh, I'm sniffing smoke. So you have to also check all those ones to see. Because if you don't know the client, if you know the client is having olfactory hallucinations and client says, I'm perceiving smoke, it will direct you, the one taking care of the client, your attention that then maybe probably there is fire outbreak somewhere. So if you take care of clients, you end up checking for where the fire is coming from. For all you know, you realize that client is having olfactory hallucinations. So all these things are very important when you're assessing the client. You also have gustatory. Gustatory has to do with taste. Client will tell you, sometimes they'll taste the food and tell you that no, the food tastes like dead body. So they have unusual taste as well. Sometimes they'll not even taste the food. They'll give you explanations and complaints that the food is not nice. Sometimes they'll tell you that the porridge, there is no sugar, there is no salt in the soup. Despite the fact that they've not tasted it, they'll give you the point blank um, explanation. So you have to also assess the client for that. So that if you meet a client like that, say, oh, there's no sugar. The funny thing is that if client tells you that there's no sugar in the porridge, the best way to go is that give him the porridge, give him the sugar to add it himself. And the funny thing is that they'll just pinch it and drop it and tell you that it's okay. So these are some of the ways that you can also use to resolve such problems. Because if you don't take care, client will tell you, and if you pour for him by yourself, he'll tell you that there's no sugar, there's no salt. So sometimes you allow them to pinch it themselves, and they'll just use their fingers to pinch it, and that will be okay for them. Then also check for illusions. How do clients interpret something? Illusion, simple misinterpretation of real external stimulus. Belt will be there, clients will tell you that it's snake. They will see female breasts and they will tell you that they are snakes. Not that they are intentionally saying that, it is a brain that is explaining what they are seeing to them as snake. So it is a disorder of imbalance in their brain. They also have depersonalization. You have to also put this one into consideration. Depersonalization simply means a disturbance of self-awareness in which the individual feels real on detached from or unreal in relation to their own thoughts or actions. So clients will tell you that no, I'm not real. I feel like I'm watching myself from outside. Trying to tell you that no, I don't feel like the body is mine. I'm not a human being. And these things, some two are under the delusion that we call them hypochondriacal disorders, and also somatoform disorders. So that one too are part of delusions. But here, the one I'm talking about, I mean depersonalization, trying to tell you that no, I don't feel myself. I feel like I'm not the one talking. I feel I'm not from this world. You see, then you also have another one that is similar to deep personalization, which is also termed derealization. It's also a disturbance in the perception of the external world. The depersonalization has to do with the client himself or herself. But this one, client sees the things around him or around her to be unreal. So client will tell like, no, I see world to be like a movie, or client will tell that no, I'm not on this world, I'm dreaming. Everything around me is a dream or it's a movie. Sometimes they will look at things and so no, that everything is blurry. I can't see anything. They look foggy. So this one too is called the personal derealization. Then another point on the domain is cognition. Cognition also comes with subtypes or subheadings that I would like to take you through. And the first one is consciousness. You check the consciousness of the client. Is the client alert, drowsy, stuporous, or comatose? Most cases, the ones that they force them before they bring them, if the person was brought in with by a nurse, sometimes they do sedate them. So clients will come to the ward being drowsy, and mostly the addicts too, because sometimes they leave the house, they'll go and stay somewhere and be using the drugs. Sometimes before they'll find them, they are even in coma. So bring them in being comatose. So you check for all that level of consciousness of which the clients came for the assessment. They also check for orientation, which is still under the cognition. You assess the client, whether the client is orientated to place, person, and time. So you can ask clients about, oh, please, me that you're having a chat with me, who am I? Am I a doctor? Am I a nurse? Am I a soldier? Am I a police? Based on what client will tell you, will let you know whether client is orientated to person or not. Then place you can ask clients, looking at the environment around you, where do you think you are? Sometimes clients will tell you that I'm in a mosque, I'm in a church, despite the fact that they are in a hospital. So you ask clients, whatever he or she says, you record it and you give you a clue whether client is orientated to place or not. Then time, you can ask clients that are looking at the weather and the environment. What exactly can you say about the environment? Is it daytime? Is it morning? Or is it night? Or you can even tell him what time could it actually be. So mostly time, even we that we are seeing, sometimes you don't have, we might not get it right if you don't look our at our time or our watches. We hardly get it correct. So sometimes the time, maybe they might say it, so they will give you approximation. So you have to put consideration on that. But you can ask them, is it morning, is it afternoon, or is evening, which is very easy. Then under the cognition, you can also assess for attention and concentration. Here you can ask client to maybe give you multiples of 7 to check whether client can be consistent by saying that or not. Sometimes you can ask client that, oh, spell some particular word from the back to the front. Maybe you can ask client to spell the word book. The client will be like, oh, book KOOB. That means he's spelling from the back to the front. So it can tell you how concentrated or attention the client is having. Then under the same cognition, you also check for memory. Is the client having good memory or bad memory, whatever? And then under the memory, we also have three parts. We have the recent memory, we have the immediate memory, we have the recent memory, then we have the remote memory. The immediate memory, you can ask client that, say after me when I say something, you can say book. If client is able to repeat after you, client is having immediate memory. Then the recent memory, you can also call it anterograde memory. That one could be minutes or maybe some hours, few hours. So you can ask client to maybe keep this word, book, pen, pencil. I'm going to ask you the next 5 minutes later. If you ask client and he or she is able to say it, then client's recent memory is working perfectly. If he or she is able to say two or one, or is not able to say any at all, it tells you that client is having amnesia or something about his recent memory, which is the anterograde. Then you also have the remote memory, which is the retrograde memory, which could be things in the past for hours, many hours or days, months, years. You can ask clients about his basic school, the name of his basic school, his future, and those things. So these are the things that you have to assess the client on. So under the same cognition, you also check for abstract thinking. How does the client think in terms of abstractly? So you ask interpretations of some proverbs. It's better you put it that way. Sometimes you can ask client that people who live in glass houses should not throw stones. How do you understand? Client will, how he or she is going to explain to you, give you a clue that abstractly clients understand well or not. Or sometimes to mostly they ask client that, assuming there are 4 birds on the tree and you shoot one, how many will be left on the tree? So how client is going to answer this one to give you a clue that abstractly client is thinking well or not. Then another cognition, you also have intelligence. Intelligence too is very important. This one is based on, whilst you're having a discussion with the client, the vocabs that client is using, his educational levels. If you have taken the identifications properly, it can also tell you the client's educational level. Then also the knowledge level of the client can tell you whether the client is intelligent or not intelligent. Then one of the most important thing that is good on the assessment, one of the best domains that is very important is insight. If client tells you that I'm not sick, it's hard to work with clients. So sometimes nothing that you say that they will attend to. Everything that you say they want to obey to the instructions. So when you are assessing clients, you have to really find out whether client knows that he or she is having problem. So sometimes they will completely deny that they are not sick, so let them go home. Sometimes they have slight awareness. Sometimes too, they are aware that they are not feeling well, they're having a particular problem, but then they blames others for their own problems or their condition. Then sometimes too, they are aware, but they will deny treatment. They'll tell you that yes, I'm the one suffering, I'm the one having the bipolar, I'm the one having the schizophrenia, I'm the one having the depression, I'm the one having everything that you are seeing, but I don't want you to treat me. Let me go home. I don't need any treatment. It's difficult to attend to clients like this. And intellectually, some are very having they're having good insight, they know their condition, they can even tell you, I mean, the causes of their condition, the medications that are used to treat the condition. And emotional wise, some are very insightful that they can even tell you the cost, the harm the condition is causing to the family, the challenges they are facing in the family, and how it is being affected, they've been affected. So when you are assessing clients, you have to put that one too into consideration. Very important. Then the last one, but not the least, is judgment. Here, you are going to ask how clients make judgments. So you ask questions, ask things hypothetically, asking client to answer you. So you're going to ask whether clients will answer appropriately or not. So you can ask clients like, what will you do if you smell smoke in crowded buildings or crowded area? Then there is a judgment the client is going to give you will say whether the judgment is intact or not intact. Sometimes you can ask clients that, can you walk on water, or probably maybe stream, river, whatever. Depending on what client is going to tell you, can let you know whether client is having good judgment or not. So here brings us to the end of the clinical mental status examination or mental status examination